Drugs for treating reproductive and genitourinary concerns. The objectives include describing sexual health and the medications used to prevent pregnancy, summarizing the black box warnings for the use of hormonal contraceptives, discuss the advantages and the disadvantages of long-acting, reversible contraception, summarizing the medications used to prevent bacterial and viral sexually transmitted infections, and discuss treatments for common reproductive and urogenital concerns. Reproductive health refers to the diseases, disorders, and conditions that affect the functions of the male and female reproductive systems during all stages of life. Sexual health addresses contraception, sexually transmitted infections, also known as STIs, and erectile dysfunction. The athletic trainer must be able to educate athletes and other physically active people about the most common reproductive and sexual health considerations and conditions encountered in the traditional athletic training setting. Contraception, also called birth control, is the deliberate use of medicine or device or technique to prevent pregnancy. There are many different types of contraceptives that are available. For example, the use of the birth control pill is common among people who work with athletic trainers. The athletic trainer should be able to describe classifications and characteristics for the use of the following specific contraceptive methods: short-acting hormonal contraceptives, long-acting reversible contraceptives, subdermal contraceptive implants, and emergency contraception. The effectiveness of contraception is based on its method and its correct use. Competitive athletes should discuss their goals and desires of a contraception with their provider as needed. This is figure 17.1, the effectiveness of various contraceptives in decreasing order. The classification of contraceptive methods. There are various types of contraceptive methods, including short-acting hormonal contraceptives, including combinational oral contraceptives, the progesterone-only oral contraceptives, contraceptive patches, and contraceptive vaginal rings. Long-acting reversible contraceptives, such as contraceptive hormonal injections, intrauterine devices, either copper only or with hormones, and subdermal contraceptive implants. There are barrier methods, such as the contraceptive sponge, cervical cap or diaphragm, the female condom, male condom, or spermicide alone. And then there is emergency contraception. Several differences exist between contraceptives. Hormone-containing contraceptives have more side effects than non-hormonal contraceptives. Combinational hormonal contraceptives are contraceptive products that contain an estrogen combined with a progesterone. Hormonal contraceptives can be safely used by most women. Athletic trainers must reiterate to patients that no hormonal contraceptives protect against STIs, including HIV. Combinational oral contraceptives are medications that require a prescription and contain an estrogen and progesterone. Oral contraceptives mimic ovarian hormones. Once ingested, they inhibit the release of gonadotropin-releasing hormones by the hypothalamus, thus inhibiting the release of the pituitary hormone that stimulates ovulation. Pregnancy is prevented by suppressing ovulation, the release of the egg from the ovary, thinning the lining of the uterus or the endometrium, and thus preventing a fertilized egg from implanting, and thickening the cervical mucus, making it impenetrable to the sperm. Oral contraceptives may contain either a combination of the hormone estrogen and a progesterone, or a progesterone alone. Oral contraceptives are available in different mixtures of active and inactive pills, depending on how frequently a menstrual cycle is desired. Oral contraceptives have some very important health benefits. High and low dose combination oral contraceptives decrease the risk of endometrial cancer and ovarian cancer by about 50% for greater than 20 years after the oral contraceptives are stopped. They also decrease the risk of benign ovarian tumors, abnormal vaginal bleeding, dysmenorrhea, osteoporosis, premenstrual dysphoric disorder, iron deficiency anemia, benign breast disorders, and functional ovarian cysts, ectopic pregnancy, and infection and inflammation of the fallopian tubes, which can impair fertility, occurs less frequency in oral contraceptive users. It has been suggested that estrogen may have an anabolic effect, that progesterone may have a catabolic effect, and that oral contraceptives negatively affect athletic performance. A study comparing isokinetic knee strength, hand grip strength, and hop testing indicated no significant differences between the times of oral contraceptive use and non-oral contraceptive use, comparing the two conditions in the same patients. Little evidence exists correlating hormone fluctuations of oral contraceptive cycles with aerobic performance, but ventilations and oxygen consumption may be influenced by oral contraception progesterone content. No evidence exists that oral contraceptive influence anaerobic power, and modern oral contraceptive formulas do not offer a sufficient androgenic effect on muscle strength. The contraceptive patch. This has two hormones, estrogen and progesterone, that stop the ovaries from releasing eggs and thickening the cervical mucus, which keeps sperm from getting to the egg. Due to the risk of venous thromboembolism, the FDA has a black box warning. Thus, the patient and provider should have appropriate discussions if this medication is prescribed. The vaginal ring. In the United States, only one vaginal ring, called the NuvaRing, is currently available. This vaginal ring is flexible, soft, and transparent. It comes in one size, which is 58 millimeters in diameter and 4 millimeters thick. Each ring releases 15 micrograms of estrogen and 120 micrograms of progesterone daily. These hormones are absorbed through the vaginal epithelium. When a vaginal ring is used, hormone blood levels are relatively consistent. The ring is typically left in place for 3 weeks and then removed for 1 week to allow for withdrawal bleeding. Contraceptive efficacy and adverse effects with vaginal rings are similar to those used in oral contraceptives, but adherence may be better than with pills taken daily because the user inserts the ring just once a month. The NuvaRing has an FDA black box warning indicating that women who are over the age of 35 years of age and smoke cigarettes are at risk of developing significant heart and blood-related side effects. Long-acting reversible contraception. Long-acting reversible contraceptives are methods that last for several years. They may be removed at any time to resume fertility. A prescription is required for these types of contraception. However, once started, this type of birth control is highly effective and easy to use. The athletic trainer should be able to provide information on options for the following forms of long-acting reversible contraception. This includes contraceptive hormone injections, subdermal contraceptive implants, and intrauterine devices. Contraceptive hormone injections are long-acting injectable formulas that are administered every 3 months by deep intramuscular injection into the gluteal or deltoid muscle. These are effective contraceptive hormonal serum levels that are usually attained as early as 24 hours after the injection and are maintained for at least 14 weeks. The most common adverse effect of the Depo-Provera shot is irregular vaginal bleeding. In the 3 months after the first injection, about 30% of women have amenorrhea. Because Depo-Provera has a long duration of action, ovulation may be delayed for up to 18 months after the last injection. After ovulation occurs, fertility is usually rapidly restored. Depo-Provera contraceptive injection has a black box warning that indicates users may lose significant bone mineral density. Subdermal contraceptive implants. Progesterone-only subdermal implants are a type of long-acting contraception. Nexplanon is the only progesterone implant available in the United States. It is a long-acting, up to 3 years, reversible hormonal contraceptive method. This 4-centimeter, match-sized single-rod implant can be subdermally inserted with a trocar at a point 8 to 10 centimeters above the medial epicondyle, avoiding the groove between the bicep and the tricep. This location is intended to avoid the large blood vessels and nerves lying within and surrounding the sulcus, and no skin incision is required. The implant provides effective contraception for up to 3 years. In some studies, however, the efficacy persisted up to 5 years. The most common adverse effects are similar to those experienced with other progesterones, including irregular vaginal bleeding, amenorrhea, and headache. Some women experience changes in menstrual bleeding patterns, weight gain, and acne. Less common risks involve complications at the insertion and removal of the implant, including pain, bleeding, scarring, infection, and movement of the implant to another part of the body, ectopic pregnancy, and ovarian cyst. Rarely, some women will have blood clots, heart attacks, or strokes. Intrauterine devices is a small T-shaped device that is inserted through the vagina into the uterus by a trained healthcare provider to prevent implantation of a fertilized egg. An IUD provides contraception for 3 to 10 years depending on the type. IUDs do not protect against sexually transmitted infections, including HIV. The athletic trainer should be familiar with the two types of IUDs and be able to explain how they intervene in the pregnancy process. Copper-bearing IUDs are effective for up to 10 years and have a cumulative 12-year pregnancy rate of less than 2%. The Mirena IUD can be used for 3 to 5 years. Vaginal bleeding stops completely within 1 year of insertion in 6% of women using the 3-year IUD, and in 20% of women using the 5-year IUD Mirena. The barrier method. Barrier methods with spermicide are interventions used by men and women to prevent sperm from entering the uterus. Most spermicides contain non-oxynol 9, which immobilize or kills sperm before they can enter the uterus by damaging sperm cell membranes, thus preventing fertilization. The following barrier methods are available over the counter: spermicides and contraceptive sponges. Emergency contraception may involve either the use of emergency contraceptive pill, sometimes called the morning after pill, or insertion of a copper-bearing IUD after unprotected sex. Emergency contraception can prevent up to 95% of pregnancies when taken within 5 days after intercourse. Emergency contraceptive methods cannot interrupt an established pregnancy or harm a developing embryo. Sexually transmitted infections. In 2006, in the United States, approximately 1 million adolescents and young adults ages 10 to 24 years of age were reported to have chlamydia, gonorrhea, or syphilis. Also in the United States, 25% of females ages 15 to 19 years of age and 45% of those ages 20 to 24 years had evidence of infection with a human papillomavirus during 2023 and 2024. Sexually transmitted infections are a variety of clinical syndromes and infections caused by pathogens that can be acquired and transmitted through sexual activity. Physicians and other healthcare providers play a critical role in preventing and treating STDs. Common bacterial infections include chlamydia, pelvic inflammatory disease, or PID, gonorrhea, syphilis, and trichomoniasis. Common signs and symptoms of chlamydia include abdominal pain, dysuria, testicular pain, discharge from the vagina or penis. Viral infections include human papillomavirus, HPV, herpes simplex virus, HSV, and the human immunodeficiency virus, HIV. Women have pathologies relating to their menstrual, obstetric, or gynecological history such as endometriosis, urinary tract infections, and osteoporosis. Other conditions may include erectile dysfunction, which specifically affects men. Another condition that we'll focus on is kidney stones, which can occur in women but is more common in men. Although an athletic trainer does not prescribe medication, they should have a general knowledge of common medications used to treat reproductive and urogenital concerns in advising patients about their conditions. The urinary tract infections. Urinary tract, which spans the kidney to the urethral meatus, is normally sterile and resistant to bacterial colonization, despite frequent contamination of the distal urethra with bacteria from the colon and the anus. The major defense against cystitis, or urinary tract infection, is completely emptying the bladder during urination. About 95% of UTIs occur when bacteria ascends through the urethra to the bladder and then ascends to the ureter to the kidney. Women are at a greater risk of developing a UTI than men because of the shorter distance between the urethra and both the anus and the urethral opening to the bladder. Infection limited to the bladder can be painful and annoying. However, serious consequences can occur if a UTI spreads to the kidneys. Sexual intercourse can lead to cystitis, but a person does not have to be sexually active to develop a UTI. Prescribers typically treat a UTI with antibiotics. Often symptoms resolve within a few days. Patients may also be prescribed a pain medication that numbs the bladder and urethra to relieve the burning experienced while urinating, but pain is usually relieved soon after starting the antibiotic. Osteoporosis is a disease identified by low bone mass and structural deterioration of bone tissue. Osteopenia is a term that defines bone density that is abnormal, but not as low as that seen in osteoporosis. Although osteoporosis is often associated with women, among men greater than 50 years old, 4 to 6% are diagnosed with osteoporosis and 33 to 47% have osteopenia. Over-the-counter medications such as vitamin D and calcium can help. Endometriosis occurs when bits of the tissue that line the uterus or the endometrium grow on other pelvic organs, such as the ovaries or the fallopian tubes. Outside the uterus, endometrial tissue thickens and bleeds just as the normal endometrium does during the menstrual cycle. Endometriosis occurs when the uterine lining becomes inflamed from infection. Endometriosis is likely to be a shorter-term condition that is easier to treat than endometriosis. Symptoms depend on the location of the tissue and may include dysmenorrhea, infertility, dysuria, and pain during defecation. Pharmacological treatments for endometriosis suppress ovarian function to inhibit the growth and activity of endometriotic implants. We often see hormonal contraceptives, NSAIDs, gonadotropin-releasing hormone analogs, and cannabis. Kidney stones. Kidney stones are hard deposits made of minerals and salts that form in the kidney. Caliculi vary in size from microscopic crystalline foci to several centimeters in diameter. During passage, caliculi may irritate the ureter and become lodged, obstructing urine flow and affecting renal function. Typical callus must have a diameter of greater than 5 millimeters to become lodged. Calli less than 5 millimeters are likely to pass spontaneously. Severe pain, often accompanied by nausea and vomiting, usually occurs when calli pass in the ureter and cause acute obstruction. Stones can cause fever, chills, and blood in the urine, also known as hematuria. Initial treatment is likely to be over-the-counter pain relievers and NSAIDs. However, advanced treatment primarily involves analgesia for pain, including opioids such as morphine, and for rapid onset, fentanyl for persistent or infection-causing caliculi. Complete removal using endoscopic techniques may be performed. Erectile dysfunction, formerly called impotence, affects up to 20 million men in the United States. The prevalence of partial or complete ED is greater than 50% in men aged 40 to 70 years of age and increases with age. The most common vascular cause of erectile dysfunction is arteriosclerosis of the cavernous arteries of the penis, often caused by smoking and diabetes. Arteriosclerosis and aging decrease the capacity for dilation of the arterial blood vessels and smooth muscle relaxation, limiting the amount of blood that can enter the penis. Diabetic neuropathy and surgical injury are particularly common causes of erectile dysfunction. Effective treatments are available for erectile dysfunction, many which involve resolving the underlying cause. However, the athletic trainer should have a general understanding of the first line of treatment, usually with an oral medication. The athletic trainer must inform the patient of the adverse effects of erectile dysfunction medications, including the potential for the following: decreased blood pressure, priapism, headaches, cardiac arrhythmia, and the potential myocardial infarction secondary to lower blood pressure. In summary, athletes should be familiar with pharmacological interventions for reproductive health concerns. Athletes should be referred to the appropriate providers as needed. There are various antibiotic options to treat diseases associated with reproductive and sexual health, and athletic trainers should be familiar with many of them.